Did you know that most hospitalized patients get one of these three drugs for nausea? Ondansetron or Zofran, Metoclopramide or Reglan, and Promethazine or Phenergan? It's not because they are the only ones, but because they are available in almost all USA hospitals' formularies. In this video, we'll get to know them better so we use them better and manage or avoid their side effects. Some information will surprise you in this video. This is the second video of our video series, First Week of Residency Tips. A link to the first video is provided below. Let's start. Ondansetron or Zofran is a serotonin receptor antagonist. It's probably the most commonly used one in inpatient settings. It's effective in most cases and safer relative to the other antiemetics. However, you need to be aware of the following side effects. Headaches. Headaches is the most reported side effects of Zofran or Ondansetron, and if it happens, it is severe and typically occurs within minutes of administrations and lasts minutes to hours. Acetaminophen or acetaminophen with caffeine can be used to alleviate this. QT prolongation. Ondansetron prolongs all intervals, not just the QT interval. It prolongs the PR interval and the QRS duration as well. It may also cause bradycardia. Look at the EKG before ordering Ondansetron and correct any hypokalemia or hypomagnesemia. Don't use Ondansetron if prolonged QTC exists. Use Metoclopramide or Promethazine instead. Constipation is another important side effect of Ondansetron, especially with repetitive doses. Stool softener and laxative can be used to solve this problem. Now, Ondansetron comes in IV, IM, and oral forms. The dissolved tablets form has been discontinued in the USA. IV form is the most commonly used in inpatient settings. It comes in 4 or 8 mg and is given every 4 or 6 or 8 hours as needed. Ondansetron is usually the first one that comes to my mind when thinking about ordering a nausea medicine, with a few exceptions that I'll discuss soon. Before we continue, if you would like to receive a summary of this video, please subscribe to my Substack. The link is provided below. Let's move to Metoclopramide and Promethazine. These two antiemetics are closely related. They both work by blocking dopamine receptors, but with slight differences. Promethazine or Phenergan blocks these receptors centrally only in the CNS, while Metoclopramide blocks them centrally and peripherally in the GI tract, which explains its prokinetic effect. Additionally, Promethazine has an antihistamine effect, which explains its sedative effect. Their antidopaminergic activity may lead to drug-induced extrapyramidal reaction, drowsiness, fatigue, dizziness, and confusion. For the drug-induced extrapyramidal reactions, acute dystonia and akathisia are the two conditions we need to watch out for. They may develop quickly within 24 to 48 hours of administering the medications. In the description field, you will find a link to a 2-minute video to demonstrate akathisia and acute dystonia. Please watch that video so you won't miss these conditions in the future. If they develop, discontinue the medication immediately. For acute dystonia, IV diphenhydramine 50 mg times 1 typically results in the resolution of acute dystonic reaction within minutes. IV Valium or diazepam 5 to 10 mg is a good alternative if needed. Oral diphenhydramine or Benadryl 50 mg PO every 6 hours times 1 to 2 days should be given to prevent recurrence. There is no definitive treatment for acute akathisia, but it will eventually get better and resolve. It may take time though. To help alleviate these symptoms, propranolol 40 mg to 80 mg once or twice daily can be tried. What you are going to see more with Metoclopramide or Promethazine is the drowsiness, fatigue, dizziness, and confusion. Promethazine causes more sedation given its antihistamine effect, and this sedative effect can be prolonged, particularly in elderlies. Please avoid giving Metoclopramide or Promethazine simultaneously with other sedative agents like narcotics or benzodiazepines. Metoclopramide or Reglan comes in oral, IV, and nasal spray forms. It comes in 5, 10, or 20 mg doses and may be given every 4 to 6 hours as needed. Renal adjustments is necessary if creatinine clearance is less than 60 ml per minute. Promethazine comes in IV, IM, oral, and rectal form, and it comes in 12.5 to 25 milligram doses that can be given every 4 to 6 hours as needed. I know most of us prescribe this in IV form in inpatient settings, but beware that IV and IM promethazine administration carries the risk of severe tissue damage and necrosis and chemical irritation. For that reason, it should be generally avoided. I still use IV promethazine, but only if ondansetron and metoclopramide are ineffective or cannot be used and the patient needs something quick or unable to tolerate PO promethazine. Which one should I use first? In most cases, we tend to reflexively pick ondansetron or Zofran, which can be okay, although some conditions, dopamine receptor antagonists, metoclopramide and promethazine are preferred, like migraine-induced nausea and vomiting. Also, promethazine is considered first line in hyperemesis gravidarum. Some avoid using metoclopramide in cases of diarrhea given its prokinetic effect. This is incorrect. It's safe to use Reglan or metoclopramide in such cases. Now, of course, there are other antiemetics. Still, some are not available in hospitals' formularies given their high price tags, like neurokinin 1 receptor antagonists such as aprepitant, or second generation serotonin receptor antagonists such as ondansetron. These are mainly used outpatient for the prevention and treatment of chemotherapy-induced nausea and vomiting. Very rarely, I don't think you will find it in any hospital given how expensive they are. Antihistamines such as Meclizine are best for vestibular neuritis-induced nausea. Cannabinoids such as Dronabinol, benzodiazepine, particularly lorazepam and alprazolam, glucocorticoid, particularly dexamethasone, all have variable antiemetic activities. These agents work better as an add-on to one of the 3 agents we mentioned earlier if nausea is inadequately controlled. In the end, if you find this video is useful, please give it a like, share it with your colleagues, and subscribe to the channel if you have not done so. And remember that you can get a summary of this video and access to the previous video summaries by subscribing to my Substack. The link is provided below. Thanks for watching.